Okay. So since morning, we've been talking about healthcare challenges, potential ideas, how technology can tackle some of those challenges. And we've also tried to take perspectives from different markets. We initially focused on India, at least from a challenge standpoint. And then we also got some perspectives from Japan as to what they're doing there and so on. Very importantly, I think we recognize that technology is changing and changing rapidly. And needless to say, at least in the first world, in the developed world, there is a lot happening. There is a lot happening that is helping us to tackle challenges and also meet unmet needs. But then all those innovations, all those advancements, is that good enough for where we are in India? In the emerging world, are these same ideas, technological advancements immediately applicable? Do we have enough to tackle the access to care challenges? The next discussion is all about that. So we're going to have Jeroen Tas, Head of Innovation Strategy, talk to Dr. Anoop Amarnath. We're very happy to have him here, and you will know very soon why. Dr. Amarnath is a gold medalist, trained extensively in the United Kingdom, and one of the only few geriatricians in the country. When you look at him, you'll know why the field is so special. He has specialized in geriatric medicine from the Royal College of Physicians, London. He has worked across various hospitals across UK. During a stint at these hospitals, most notably at the Sunderland Royal Hospital, Dr. Amarnath has had the opportunity to work extensively in the various subspecialties of geriatric medicine. He has, in fact, been one of the very few to specialize in geriatric nephrology. The American Society of Nephrology awarded him a certificate during their annual conference in 2009 in San Diego. He was chosen to be the organizing registrar for the prestigious MRCP exams conducted by the Royal College of Physicians at York Hospitals. Dr. Amarnath has his specialty interest in geriatric nephrology. He's currently the chairman of geriatric medicine at the Manipal group of hospitals. Dr. Amarnath and Mr. Jeroen Tas, please.
Thank you, Jeroen.
We already had a very interesting pre-discussion, so I suggest we just continue our dialogue.
Sure.
But let's start with your specialty. You're dealing with elderly people, care for elderly people. We know that they have a specific set of issues that is the mic not working? Okay, we'll do this way. So they have special needs. Many of them have multiple chronic diseases. Many of them have mental disorientation. They need to take multiple meds. They need to be watched over. Tell me a little bit what you see in daily practice and what you believe the needs are. And then let's talk a little bit about how we can address this in a better, scalable manner.
Sure. So thank you, everyone, and thanks, Jeroen, for the introduction. Mr. Sriram, thanks for the lovely introduction. I don't think both of us can be as funny as Dr. Jagdish, but we'll try our best. So yes, I'm a geriatrician, and as Mr. Sriram said, a pediatric-looking geriatrician, if I can use that term. But yeah, I think on a day-to-day basis, what we were discussing earlier on, India has the second largest population of elderly people in the world. That's above the age of 60, and about 8 to 10% of the Indian population is elderly. And as you rightly pointed out, the disease manifestations are entirely different. It's never a single organ involvement. Whenever they come into hospital, it's not a single organ that's involved. It's always multiple issues that we deal with. Your kidneys are not functioning, and at the same time, your heart's not functioning. So it's a very fine balance that you need to maintain in terms of taking care of them. But the issue that we face in India is the lack of qualified manpower. You have very few geriatricians across the country. You have very few hospitals which have the specialty. And I think that's where technology is going to play a big role in terms of how we disseminate expertise which is in silos in one or two centers, and then how that same kind of expertise can be delivered across the country. This is a problem not just in India, but in certain countries like, say, Japan, where you have a huge elderly population and very less qualified people. So I think the solutions that we come up here, I think, are going to be applicable across the world. So whether it's in US or the NHS, where we clearly see that the amount of people receiving care, the elderly, is far more than the amount of people who are paying into the NHS. So I think across the world, elderly, taking care of elderly is going to be a huge challenge, and I personally feel that technology is the means to an end.
So I've been personally involved in a very interesting project in the US where we took 2,000 elderly people that have 5, 6 chronic diseases, and then we started monitoring them from home. So we basically said, we're going to help you as much as possible. You do your little routines, you do your blood pressure, stand on a weight scale, maybe SpO2. We'll ask you 5, 6 questions, contextualized. And we have a home nurse coming as and when needed. And the results were amazing. So actually 60% less emergency care, 50% less readmissions, 30% net cost savings. So you would say, okay, everybody will jump on this and this will become the standard of care. It didn't happen.
Right.
Why didn't it happen? Because the reimbursement system didn't align to virtual care, which has this continuous interaction. So it's not legally fragmented into a consult, a procedure, a visit, etc. So how do you see the model evolving to actually stimulate this kind of care, where you can actually do this at scale with dramatically fewer professional health providers?
Right. Now, I think one of the phrases or words which have been going around a lot across this conference and the other conferences which I've been discussing, we had the IoT Congress in the morning. So I think the key word is ecosystem. So it cannot be in silos. So I cannot have a hospital and then expect them to come across to the hospital. And the ecosystem is something which is a given. It's a mandatory thing. Unless we have that, I don't think we can improve the healthcare provision. But even more than having an ecosystem, I think the fundamental thing is the regulatory environment. Me as a doctor, even in this day and age, I cannot legally prescribe over the phone or an email. So the Medical Council of India makes that illegal, and whether it's an e-consultation or e-prescription, everything is illegal. So I think if you're looking at healthcare reaching out to the masses, these are the fundamental things that we need to address. It's very good that we were coming up with the National Digital Health Policy and the National Digital Health Mission. And one of the things which we've been discussing with the government is that how do you make this legalized? So can I prescribe over the phone? Can I consult over the phone, do a teleconsult? Is it legal? So I think once the regulatory framework is clear, I think that's exactly when the things would take off.
It sounds like that regulation originates in a time when you couldn't have the full context of the patient, therefore, consult maybe of lower quality, consult over the phone. But now, when we had a pre-discussion, you talked about the digital health plan of the government, where, there will be personal health records that are hopefully longitudinal in nature, that can give you that contextualized information that could probably help you give the right consult at a distance.
Right.
So how do you see that evolve? Do you believe these regulatory barriers will be overcome?
We're very positive about the fact that the regulatory barriers can be overcome. So it's about convincing people who make the decisions that what we are suggesting to them makes sense. In the sense that if you look at, when a patient is coming to my clinic, so I do a prescription, I evaluate the patient, and then what does that prescription contain? One, it contains patient demographics, who the patient is, where he or she is, the age. Number two, the doctor demographics, in the sense that who am I qualified to do it, what's my licensure, and things like that. And the third one is the drug demographics, which medicine, what frequency, how many days, what allergies, and so on. So what we're discussing with the government is if a prescription satisfies these three criteria, the doctor demographics, the drug demographics, and the patient demographics, there's no reason why it should be illegal. So it's more on the basic principles. If it holds good for brick and mortar, it has to hold good for digital. And then as long as it satisfies what is required in the brick and mortar. So this is the principle in which, through which we're discussing with the government. I'm really hopeful that it should come through.
So I think we talk, there are a couple of barriers, obviously, for that may inhibit scale, but there are a lot of opportunities. So specifically, you see the opportunities of getting that longitudinal data, but then starting applying artificial intelligence in the background that can monitor a patient and maybe trigger you when it's time to intervene, and maybe even guide you on how to do that intervention based on looking at large populations. So do you see a role of that technology in the digital health framework?
Yeah, absolutely. And if you look at AI, I would say 90% is hype and 10% is reality.
Yeah, but that reality can be groundbreaking.
Absolutely. So, and the reason I say that is because, you have a lot of these companies, startups, and no better place than Bangalore for startups to come and say that, look, we've got this groundbreaking AI, do you want to use it? And it's always like, I've got this solution, and do you want to find a problem for that? So it never works that way. And we've been one of the few hospitals which we've used IBM Watson for oncology. And it's been a good learning experience when we use AI for oncology. And yes, about 1.5 million pages of data is what you get at the click of a button within 60 seconds. So it's a huge tool for me as a clinician to have. But then we were also one of the few centers who did the first concordance study in AI. And what we looked at is the decision that, as a doctor, we give as a part of tumor board, and the decision which the AI system gives. There's almost about a 93% concordance. So essentially, it is doing the role of a doctor to similar extent. But the fallacy which we saw was the doctor said, look, it's just telling what I already know, so do I really need to use that? So that's the fallacy of it. But going forward, I think the areas in which AI is going to help us is in disease prognosis. Now, we talked about this example during lunchtime, and I'd like to share this with the audience. A study which we did earlier on, which we looked at progression of kidney disease in Indian elderly population. So normally the rate of kidney decline is about 1%. But the study which we did here in India amongst elderly diabetics, we saw that the rate of progression was about 2.5% in non-diabetics and about 4% in diabetic population. Now, imagine if I had this system which could clearly predict the rate of progression from no kidney disease to dialysis. So I know for sure that if the lifetime risk of a person developing kidney failure is about 1.2%, but if I put in diabetes, I know that the risk is going to be higher. But then at a population of 1.3 billion, I don't think any doctor can sit manually and do that. So that's where these systems are going to come into picture. But then there's this saying, I'm sure most of you have heard about it, junk in and junk out. So you feed junk into an AI system, you're going to get junk outside. So it has to be clinician-led, and then determining what parameters I want to measure and what's the standard progression rate, and then use the AI systems and then come up with an actual outcome. So I think it's very important that we use AI in the right context, and the quality of data that goes into it is paramount.
Yeah, I think you make a very good point, and I discussed it with many doctors in the US where they say, well, the data we have in our electronic medical record systems, I cannot fully trust it because it's optimized for liability and reimbursement rather than clinical outcomes. So,
True.
I think when we talk about data standards, like HL7, FHIR, etc., I think we also should look at data quality standards that ensure that the data that's feeding the AI is actually of sufficient quality to truly predict those outcomes. You said something that kind of intrigued me. Basically, you say, okay, we can look at the overall population is 1.2%. But if we stratify further, obviously the risk increases. And if we go further and further, and we can truly at a granular level, risk stratify patients, the way we provide the care, the way we conduct the tests can become much more proactive and therefore help us avoid deterioration at the tail end. With other words, it can dramatically help improve the health of certain populations. So how do you see that in the context of what you told us about the digital health plans at scale? Because I think if we could do that, we're onto something. So if we can kind of start predicting and create these personal, almost health pathways that guide people, it should lead to way better outcomes for all.
Absolutely. So I would just take the example which we were discussing earlier, say diabetes. So I know for sure that the risk of kidney diseases and cardiac problems are much higher, at least 7 to 10% higher in diabetic population. And as a clinician, I also know that how I identify that, how I risk stratify that, and how I mitigate that risk. So let's look at each of these individual components. Number one, how do I diagnose it? So it's very simple. You have one parent who's diabetic, you have a 25% chance of getting diabetes. If you have both the parents, then you have 50% higher chance of getting diabetes. So the family history is one. HbA1c is one of the blood tests that we do to identify now to diagnose diabetes. And then at the end of every 3 months, we usually do the HbA1c to see the progression. Now, if I need to look at complications, I can do a simple urine test to find out whether you've not just got diabetes, but also have a complication from a kidney perspective. And now that I know that you have a kidney problem, I also have a solution for that. Certain medicines that have come out in the market over the last 4 or 5 years, specifically called SGLT2 inhibitors, these actually reverse the kidney dysfunction. So I know how to diagnose, I know how to predict the progression, I know what are the markers that are used to predict the progression, and hence I know the treatment as well. So it's a very personalized medicine. But then the advantage is this personalized medicine for one person holds good for about 80 to 90% of the population. So that's where it has to be a wellness perspective rather than a curative perspective.
So I just pick up on what you say. So let's say I'm high risk for diabetes. You basically create my own health path because I have to do a test, and after 3 months you look again and you prescribe me some medication. You probably also will give me some behavior advice that you may want to track as well. How do I eat, carbs and exercise, reduce stress through meditation. And you can keep tracking this because we're talking about a digital health world. And you do it for me and 10 million other people like me. You start seeing the effect of your test and the accuracy of your test and the outcome, so you can further stratify. So you know what I'm trying to get at. How can we start creating these feedback loops that keep fine-tuning these paths? Because we haven't had that ever in healthcare. So
true.
It's always been studies for certain types of population. It's never been...
And if I can use, say, an example of what is happening in the US at Haven, the company which has been set up by Amazon, JP Morgan and stuff.
Actually, that reminds me of one of these American-sounding Indian doctors, Atu Gawanda.
Exactly. So that's again, you pick up an Indian doctor, put him at the helm of it, and then that. So I think that's the model which we really need to look into, in the sense that it's the wellness model. I think that's where it is. But then, what I said a few minutes back still holds good. It's an ecosystem. As a doctor alone, I can't do that. As a device manufacturer alone, you can't do that. And as a garment alone, you can't do that. So it has to be an ecosystem of all of us coming together. And even in terms of how we're getting the manufacturers in it. Mr. Sriram, you might remember 2 years back, we had put this question out in the open, and I said, if there is one thing that you'd want to innovate on, can you please give me a non-invasive blood glucose monitor? So I think we're still waiting for that. And those are certain things that would really make a big difference to us. So imagine, one of the biggest impediments for us to monitor diabetes is that people don't want to be pricked.
Yeah.
And if we have a non-invasive thing like how we have our oxygen saturation machine, you just clip it on your finger and say, look, I know for sure that even without putting that machine, 30% of this audience here is diabetic. Some of them know about it, some of them don't know about it, but imagine what difference that device could make. And then once that device is there, I've cleared my first step of diagnosis, and then my next step of evaluation, progression, intervention, and follow-up comes in.
But you're describing a completely different healthcare system. You also putting us to the test to come up with completely new diagnostic devices. And by the way, I'm quite hopeful on that. You know, non-invasive glucose metering is still a little bit of a challenge, as is wearable blood pressure. But I'm sure we'll crack these challenges. Still, it then requires making sense of that data, which will get more complex, because we may be tracking what we eat, we may be tracking how we feel, we may be tracking what our vital signs are. But we still need to have something in the background that looks at it, interprets it, so that it can trigger you to, you know, apply your judgment, which will probably be supported by AI. And I think the biggest opportunity for AI is not giving you stuff that tells you what you already know. It's telling people who don't have access to you the same things that you know. And I think that's the bigger challenge, because it's very hard to get another 1,000 Dr. Anoops, but it may be easier to create an AI that you train.
Right.
So how do you see that?
I think that's the system of healthcare delivery that we are looking at, and I think everyone here, including you, will promise me that you heard it from me first. But what I'm trying to say is that this model, where we look at the preventive model, and then using an AI system, which is not just going to give me an individual projection of health, but also a population-based projection of health. So we've had a very interesting discussion with the Ministry of Health and Family Welfare, where they showed that, you know, you have a big screen, and then we are primarily looking at dengue, an infective disease, vector-borne disease. So which are the areas in India which are highly prone to these dengue viral illnesses? And but then if I need to prepare that and an AI system into it, the crucial thing, as I said earlier on, is what kind of data gets fed into it. So it's very important that we have systems where as soon as a dengue test is done, that gets reported onto the system. And then I can create that entire heat map, if I can use the term. And then that's exactly what the National Digital Health Mission is out to do. So you have a central repository which gets fed in by these tests which come in, and then anybody could access this repository and say that, you know, this is where dengue is more prevalent, this is where diabetes is more prevalent. And the advantage of that is, say, as a government, I can clearly decide where the money is going into in terms of sanitization and things like that, and then, you know, primordial prevention for diabetes. So I think it's very important that these AI systems sit on top of a very good disease repository, and then the access to that repository is something which, you know, me as a clinician should be shared.
That's interesting, because you know, there's a saying in the US that your zip code is more predictable of your health than your genetic code.
Absolutely.
With other words, you can look at dengue fever, but you can similarly look at socioeconomic factors. And you probably see on these heat maps that in certain places there are higher instances of lung cancer, which may be environmental. There are higher instances of cardiac disease, which may have to do with lifestyle. If you bring it down to community level, and that's where I want to go, I think ultimately we're human beings that relate to each other. We live in communities, we have families, and I know for certain that Indians really care about their parents and take care of their parents. What always surprised me, and I told the audience earlier that my daughter has type 1 diabetes, what really amazed me is that nobody ever invited my wife and me to become part of the care team of my daughter. And if there's one person who knows all about my daughter, better than any clinician, is my wife. So I believe we need to move to a system where the community is kind of the cornerstone, but plugged into these networks.
Correct.
So how do you see the emergence of truly community, family-driven care in a digital world?
As a doctor, I say this, and I'm going to stick my neck out here and say, the biggest impediment to using any new technology is the doctor himself or herself.
Your mic is fading.
Yeah.
Okay.
Okay.
Backup system.
Thank you. So I say this as a doctor, and I'm going to stick my neck out here and say that the biggest impediment to new technologies and new care delivery models are doctors themselves. And that's primarily because, all this while, it's always been a top-down approach.
Yeah.
And most of the doctors across the world, it's, my way or the highway, you deal with it. But I think what's happening of late is we're moving from an experience-based medicine to evidence-based medicine. And I think when you move to evidence-based medicine, it's about co-opting care models and not just the doctor being the single decision maker. So I think for us to change from experience-based medicine to evidence-based medicine, we need technology to provide that evidence. Say, for example, a lot of times when we treat these patients with diabetes, they bring in the continuous glucose monitor readings for us, say 15-day readings, and say, doc, look, this is what the readings I've got. So what happens then is that I'm co-opting the care along with me and my patient. So it's not a unilateral didactic decision. And I think the only way we can have a community-driven co-opted model of care is when we have an input from them in terms of evidence. But I'm very certain that in the next 5 to 10 years, we will move from just experience-based medicine to evidence-based medicine.
So last questions. I think a lot of people sense that we're, at the beginning of something big in healthcare where we provide access, personalized care. How optimistic are you? On
a scale of 10, I think at 10.
Wonderful. Thanks so much. It was a real pleasure having this dialogue.
Thank you very much.
Just a couple of minutes back, you spoke about the biggest impediment for adoption of technology is doctors. So I'll put you on the pedestal. How do I phrase it? How comfortable are you in adopting technology? Say, I'm bringing out an AI-based tool which could, supplement your skills or complement your skills. So how would you?
That question is for you.
Yeah, so I think, the reason why I said that the biggest impediment to technology in healthcare are doctors themselves is primarily because a lot of solutions that we see are solutions where we as clinicians don't see that as a problem at all. So you have these EMR, EHR systems coming, look, you put all these data into it and you're going to get a brilliant outcome out of it. But look at it from my perspective. You have about 35, 40 patients waiting outside the clinic. And then the last thing that I want to do is, the patient is sitting here, I'm looking over there and entering data over there. So that becomes very, very impersonal. And my role is towards the patient and not towards the technology. Having said that, there are a lot of technological aspects which we would want to have. As I said, a simple example would be if I need to do a population screening for diabetes, I would really want a non-invasive blood glucose monitor. So I think when I say doctors are the impediments, it's very important to understand it from our perspective, in the sense that if there's a problem that we want to solve, I think that's where we need to work together and then solve that, rather than trying to put a round peg into a square hole.
Another question here.
Sir, you were mentioning about the artificial intelligence, but that layer will sit at the top. So you were also mentioning about the top-down approach. To locally solve the problems like so many diabetes or dengue or other diseases at rural and higher levels, there should be a bottoms-up approach also, where these two meet, and the models can be tuned at different levels, and they can evolve a model with lot of So those gaps they were discussing in the morning could be filled. And finally, the artificial intelligence can be a decision maker.
Absolutely, I totally agree with you in the sense that I'll give you a small example. You know, the way the NDHM, the National Digital Health Mission, is structured is that you have a central repository into which all this data goes in. So we pick a small thing like anemia, a big problem in the rural population. So if we have a system where screening is done at the ground level and that data is fed into the central repository, the reason I said top down is the AI system cannot stay at the ground level. It has to stay at the top end. And then that gives us decision-making abilities like, is anemia more in the Bangalore rural area or is it more in some other area? And then that decision-making, that kind of data helps me in my decision-making. So when I say it's a top-down approach, yes, the data has to be gathered from ground up, but then the systems and AI systems have to sit at the top level.
Yeah, I think there are a lot of examples where it has to be community-based and community. So we have these community life centers, but also, you know, you're a geriatrician. At pediatrics, we also have big issues with maternal mortality. So we developed, we call it a backpack, where a trained midwife can go and do a fetal assessment with a Doppler, simple system, ask a couple of questions, relevant questions, which is then streamed to the cloud, which is interpreted, and then, you know, it guides the next set of questions, and then she can determine to actually contact an obstetrician and or pediatrician to support that person on the ground. So it's a community level approach, and we've seen something similar in you asked me to give examples from finance. You know, that's at the core of microfinance, where they looked at the community and they assigned somebody in the community to kind of lead and help with the assessment of the credit worthiness of the people in the village, and then connect it to a system that helps them, you know, open accounts, manage accounts. But in essence, it was a community kind of bottom-up approach to finance, which in many places changed people's lives. And again, I believe we can do that in healthcare as well.
You have a question? Yeah, please.
Yeah, go on, please.
Hi, I think I have a quick question, but probably both your perspectives could answer that. So, I mean, we had been having a lot of discussion around the data that gets generated, and different parts of the ecosystem could use it. Now, I just need your perspective on, we were talking about the population patterns in terms of disease management, or getting to know disease management based on the demographics or clinical data that we gather, right? Now, at a primary care level and at a secondary care level, there is a lot of data that needs to get generated, and as you were rightly pointing out, it's a very big pain point for the doctors to be the point of, you know, contact for that. Like, the doctors are forced to enter that same thing. Now, is there a take that you have on that? Like, what else could be an alternative? Because at a primary care center or at a secondary care center, that is the only point of source where you get this critical information before there is a prognosis of any disease, right? So what do you think of that?
I think this is something which we've always said in the past as well. The data capture has to be at the point of data generation. So that's the only way it's going to work. You're doing a blood glucose monitoring, you are generating data, and it has to be transmitted automatically. If it's a blood pressure, again, automatically. If somebody is coming and getting registered into the primary healthcare center, that's the point of data generation. So I think that making doctors an intermediate between data generation and data capture, that's a sure shot failure. So it has to be direct from data generation to data capture.
Continuing on the same thing, a question to Jeroen. Like, Vishal was giving a very key point there, reliability of the data again. So in terms of personalized care or care systems that you design for the population, you still base on this data. Now, reliability on this data, it's like bits and pieces. Like, you have diagnostic labs generating a lot of data. You have medical equipment manufacturers who have certain data with them. Then there are hospitals. It's like fragmented, right? Now, a patient could have been traversing his, I mean, like he's approaching to a primary center, to a secondary center at some point of time, or maybe he's taking his labs in different places. It's like his personal medical history is fragmented across vendors, across different diagnostic labs, across hospitals and whatnot, everywhere. Now, as an industry leader, like, what is your stand on aggregating the data so that, like Anoop was pointing out, he could make the right sense out of, I mean, making that data to be more reliable for him to take a medical decision there?
So, I think first, it's your data. So you have the right to the data wherever it's being captured. You do a diagnostic test, it should be your data. You go to a doctor, get a consult, it's your data. You go to a hospital, they capture your medical record, it's your data. So I think it should be a core principle that you have access to that data and you have the rights to share that data as you see fit. And I think that's a broader discussion. Then, of course, you want to understand the reliability of the data. So back to what you say, okay, you have to understand what's the source of the data. Is it coming from a class 2 device, a class 1 device, some consumer device? That's different quality. I can get a heart reading from my Fitbit, but is it good enough for a cardiologist to make a decision on it? I think he wants to make sure it's a FDA-approved device. So we have to understand what the source is, if it's a credible source. We also have to know that the one who fills that medical record is accredited to fill that medical record. So it's a more complex problem than just, okay, everybody dumps their data in some repository and we'll take it from there. And that's why these digital health frameworks are hugely important, where you set the boundaries, you set the guidelines and the principles. And there should be a principle like I just described. Who owns what, who has the right to what, and what's the intent. And if we don't do that, we end up what we see in the rest of the world, or even here in India, what people do with your personal data can be adverse to your own personal interests.
You want to add a perspective to it?
No, I was just asking you for the time.
No, we are
one more question.
On time, actually.
Oh.
We are beyond the...
On the dot.
Yeah, sort of, you can imagine.
Beyond the dot.
I see many more questions, so maybe in the break we can do it in a smaller circle, but okay. I can see there's a lot of interest in your opinion, Anoop, and again, I would love to continue the dialogue, and thank you so much for this discussion.
Thanks, everyone.